Most of these things revolve around replacement. All of these papers about replacement, in general, none of them are evidence-based. I mean, there are a few circumstances under which we want to give potassium, but how fast we can give it, how much we need to give, is all complicated by what I mentioned in the first part, that almost all of your potassium is intracellular. So affecting the serum value doesn't reflect a whole lot. The only thing that it does reflect, and I probably didn't emphasize enough yesterday, is the transmembrane potential across the myocardial cell has to do with its irritability. So that's probably the area where serum potassium means the most in terms of risk for arrhythmia. So while in general serum potassium isn't such a big deal, that's the area where it's most worrisome, and that's probably the rationale for replacing potassium in most cases. So as Jan's indicated in the thing here, if there's potassium's a little bit low, but it's somewhere around 3, probably oral replacement is the best. Goes in fastest, less irritating, and in general, it's not an emergency department issue. It's sort of a over the next couple of days kind of issue. For most of the causes of hypokalemia that we talked about, if your kidneys work and you're taking in orally, you will correct it, unless you're on some medication that's interfering with it dramatically. So I think in most cases, we don't need to do much of anything, maybe perhaps supplement it with something oral. And I think that's what most of the guidelines here. Now, how about if we really need to correct it more, it's less than 2, or we, quote, suspect they're at risk for arrhythmias. This is the terrible judgment call kind of thing. Almost all of the papers in here come from intensive care units, where they feel like they really need to be pumping in the potassium fast. Virtually all of them involve a central line. Very hard to give a lot of potassium through an IV, a peripheral IV, without it hurting quite a bit. So there's a couple of regimens talked about in here. Number 2, abstract number 2 is from Wayne State. It's an intensive care unit paper, and it's what I call a we did it, we liked it. A lot of people publish these sorts of things. They say, here's what we do in our ICU. We give them 20 milliequivalents an hour through the IV, and gosh, it works most of the time. You can learn something from those. There's not much else that you learn other than they seem to do it and they get away with it fine. Doesn't mean you can't give it slower or faster, but they seem to like it. The next one is it's a Canadian paper from University of Western Ontario, where they gave a we did it, we liked it, and they gave up to 40 millimoles per hour. And they said, we got away with that too. So I think, again, I don't think this should be an ER issue too much. The relationship potassium and pH, we all understand that. And then common causes for hyperkalemia. I don't think we really see hypokalemia as a life-threatening problem most of the time. Even if the numbers are low, it's hard to know if it's really causing symptoms or not, unless they're having some sort of intractable cardiac arrhythmia. We don't really know whether their low potassium is symptomatic or not. But the time when it really has to get our attention and we start paying a lot of attention to it is when we get significantly high potassium, because that's when the arrhythmia that you get is your heart stopping. I hate that when it happens. It's such a problem to get it restarted in the face of high potassium. So most of these guidelines are focused on guidance by EKG changes. And they're listed here: big peak T waves, usually around a pH of 6, prolonged PR interval around, not a pH, a potassium level of 6. Once it gets to 7, prolonged PR interval, absent P waves, and then pretty much widening the QRS and the big sine wave that we know is the sign of severe hyperkalemia. The caveat listed in here is, while we all talk about those, and those are the things we look for acutely, there certainly seem to be patients where the changes have been gradual over a long enough period of time that they don't get those changes, yet have a dramatically high potassium. I think the number one main cause of severe hyperkalemia, what is it? Lab error. Lab error. So when a number pops up and you go, oh my God, and they call you this, potassium's 9, and you just got routine electrolytes for some unjustifiable reason in a healthy person, Number one cause is going to be lab error, so always repeat that. Or at least, if it takes time to repeat it, EKG in the meantime to see. I think that's sort of the stopgap looking for major changes. So, and it's usually hemolysis, and most of the lab equipment I think nowadays is probably oversensitive to hemolysis, but you'll get some report that you have hemolysis going on, and that's the reason. Sometimes, you know, it's enough lab error. They've done the draw from the patient's IV that actually has potassium in it, things like that. But that's the number one. And then listed here are the causes. Drugs. Renal is the biggest one that I think most all of us see. If you work in a place where there is a dialysis center, I used to work in one in an inner city, the single sickest patients medically who arrive are the dialysis patients. They just haven't bothered to dialyze for a week or so. Their chief complaint is, don't feel well. You know, their pH is 6.5, their potassium is 8, their blood sugar is 500 or 700, and they don't feel well. I remember the first one of these I saw years ago. This guy had, I mean, the most amazing metabolic abnormalities I'd ever seen. And so I called the dialysis doc to get this guy off to dialysis. I said, you know, we need to write up this paper. It's a case report kind of thing. And he said, for what? He says, once a day or once a week we have patients that arrive like this. For some reason, you and I would be dead immediately with those kind of metabolic abnormalities. But I think it is true that patients who have had repeated episodes with these terrible pHs and high sugars and all that kind of stuff, they seem to survive okay. I know it's been shown for patients with repeated shock. You know, the patient has had their 10th gunshot wound to the abdomen, can tolerate a pressure in the 40s for days and come out normal, whereas most other people would be dead on the spot. For some reason, you accommodate to this. Back to the talk, though. Diet is unusual. Endocrine disorders, that's always one of the things that we think of with Addison's disease. Ooh, the high potassium, why should they have that? Something that flips through our mind. And then lysis of cells. The drug interactions, I think, besides somebody with renal failure, are the ones, at least my most recent case where dramatically high potassium was somebody on a combination of an ACE inhibitor and a potassium-sparing diuretic. It just seems to me, I mean, I don't prescribe these things much, but boy, it seems to me you would be pretty conscientious about checking potassium on these folks. And there's a couple of case reports in here with people who get dramatically high potassiums with that, which would be predictable. DKA and renal failure. You know, the trouble with renal failure with the metabolic abnormalities of DKA is they don't have the fluid loss, and they don't have the early on potassium washout that patients who have kidneys working do, so they can present with their initial problem being a high potassium. Massive blood transfusion, yes, massive blood transfusion can give you dramatically high potassiums. In the papers in here, almost all of them clear that immediately. The stress of having the transfusion, I'm sure, generates the potassium going into the cells and things clear, although there's a few case reports here of cardiac arrests in children, massive transfusion, and then cardiac arrest and known high potassium. Again, it's supposed that it was the potassium that caused the arrest. Any child that needs massive acute blood transfusions, you can bet there are probably other reasons they might arrest. Something to think about, but I don't know what else you do other than think about it. A factor during acute severe hypothermia, I think this paper said if they're really, really hypothermic and really, really hyperkalemic, they're probably dead for good, is what it says. So maybe it's a factor in predicting death. I don't know that that tells us much. Anything new out there for treating hyperkalemia? I think the answer is no. How many here, if they get a potassium back, say they need to treat it acutely, first-line drug, calcium? Okay, so you have calcium to stabilize the membranes, and then you give something to shift the potassium into the cells, either glucose or glucose and insulin. I think a lot of the papers said you really don't need the insulin if you give them glucose and they're not diabetic. They make their own insulin to do that, so you might eliminate that because in the papers where they gave insulin with it, they occasionally overshoot and get hypoglycemia. Now you get two problems to deal with, and then an ion exchange resin in order to bind it up and remove that, although that takes quite a while. Albuterol for hyperkalemia, how many know about that? Yeah, this has been around since the late 80s as a great thing to do. In fact, I think it was originally noted that it was a side effect of giving really aggressive albuterol therapy is that they would monitor these patients and draw some potassium and say, huh, look at that, low potassium from it. It's driving the potassium into the cells. And then it all goes away, of course, once the albuterol is stopped. And it, in general, in the asthmatic patient, never causes problems. So they translated that to generally the dialysis patient that has a high potassium. While you're trying to do all the other things you need to do, you can give them albuterol. And in a lot of these papers from the late 80s, it worked almost all the time, not necessarily all the time. Could be done IV for those who can give IV salbutamol. 16 here is a we did it, we liked it. When they had a real high potassium, we gave them some IV albuterol. A comparison says they're really just about the same by giving IV insulin and glucose. The choice of paralytic in the hyperkalemic patient, I think this is one of those, theoretically succinylcholine contraindicated in patients with hyperkalemia, where you might think the patient with bad burn sepsis, massive transfusion, things that are uncommon for us to deal with, this maybe burn unit issues, that kind of thing, should you not use succinylcholine. There's this last paper here, Duke did a study where they said, we looked back at all of our cases of anesthesia where they were given succinylcholine and they had on their pre-op labs hyperkalemia, and we couldn't find any problems with it. That's the kind of sort of chart review where the only reason to mention is, yes, they didn't seem to find any, but that doesn't mean it didn't happen. Maybe somebody saw transient arrhythmia, they didn't record it, it didn't get into their database, so they say they think it's safe because they didn't find it. It's hard to prove when you don't have complete data that it didn't happen, but they seem to think it's okay to do. I think at the time that this was published in 2002, we were not as conscientious about this, and you could, quote, get away with it. There may be other options now. The one thing I'd forgotten to mention was that if somebody, and this is more of an outpatient issue, but if they have serious problems with maintaining their potassium, you need to think of magnesium supplementation. They all tend to go together. Things that wash out your magnesium, wash out your potassium, and vice versa. So most of the patients who are hypokalemic from diuretics are also going to be hypomagnesiemic, regardless of their serum magnesium. We don't have a session on magnesium in this one, but in general, I think that most of the papers that I see on it say if they clinically have a syndrome or a metabolic condition that makes them at risk for low magnesium, just give them magnesium. Doesn't matter what their lab number is, because they can have depleted total body stores with a normal serum magnesium. And so if you think they need it, somebody in alcohol withdrawal is the number one, just give it to them. Same thing here, if their potassium is real low and they're having arrhythmias, just give them magnesium regardless of the number. So I think there's almost no reason to get magnesium levels, because if you're going to give it, you're going to give it. If you're not going to give it, it's not going to help you much. That's about it on potassium. Questions, comments?